Assalamu alaikum. Dear student, it is my privilege to present this lecture today. I am Dr. Mostafa Shalaby, lecturer of colorectal surgery, Mansoura University, Main Hospital. These are our objectives. We will start with the definition. Anal fissure is a tear in the epithelial lining of the anal canal distal to the dentate line. It is assumed that 7.8% of population will develop anal fissure during their life. It affects different groups of age, most commonly affect people between 20 up to 30 years old. It has equal sex distribution. However, it is slightly common in women. It is mostly multifactorial, and there are different theories for development of anal fissure. First, start with ischemic theory, decrease in the blood flow in area of enoderm, and the support of this theory, 90% of anal fissure located posterior in the midline, and this part has least blood supply. Other theory increase in the internal anal sphincter tone, and this is supported by hypertonia and manometric study of patients who have anal fissure. Hard stool causing local trauma to the epithelial lining, supporting by the fact that 20% of patients with anal fissure have constipation. Birth trauma, supported by the fact 25% of anterior fissure are women. And these theories are important while prescribing treatment for patients. Classification, it may be classified into typical and atypical, acute or chronic, and classification is important for treatment. Typical and atypical fissure, if we are going to compare regarding the location, typical located in the midline, 90% posterior, 10% anterior. However, atypical fissure lateral, away from the midline. Number for typical fissure, it is single. For atypical fissure, it is multiple in number. Presentation for typical fissure, there will be the fissure itself, maybe tried in case of chronic anal fissure. This will be associated with pain and or bleeding. For atypical anal fissure, there will be a wide variety of presentation. Associated disease present with atypical fissure like malignancy, inflammatory bowel disease, HIV, tuberculosis, or syphilis. This diagram represents the comparison between typical and atypical fissure. Typical fissure located in the midline and 90% posterior, 10% anterior. Atypical fissure located laterally and mostly associated with disease like inflammatory bowel disease, syphilis, tuberculosis, malignancy, HIV. Another way to compare or to classify fissure may be acute and chronic. And if we are starting by the timing, acute fissure, these are fissure lasting less than 6 weeks, and the fear of defecation in the patient with anal fissure, and this predisposes to constipation and worsening the trauma. Patient frequently describe the pain as a spasm or blood passing across through the anus. Rectal bleeding is a frequent, minimal, bright red in color and not related to the severity of the anal fissure. Physical examination. It is important to perform inspection of the anal region. Gentle traction of buttocks will often allow to show the fissure, and concise on the posterior midline while performing the examination. Digital rectal examination is an important part of any examination of patient with anal pathology or anal complaint. However, in patient with anal fissure, the pain may be a barrier to perform digital rectal examination, so it is preferred to postpone digital rectal examination until the pain subsides. Endoscopy is important to complement any digital rectal examination, but again, it is better to postpone it until pain subsides. If we suspecting a malignancy or inflammatory bowel disease, according to the history of clinical presentation of the patient, and you want to perform endoscopy, it's better to postpone until the pain subsides. If the fissure not observed, or if the fissure atypical, or there is a non-healing fissure, in this situation, it is better to perform examination under anesthesia. This will be in operative theater, and according to that situation, we can take a biopsy, making a culture for more evaluation. And this the comparison between acute and chronic anal fissure, depending on the clinical presentation. In case of acute anal fissure, there will be the fissure, the ulcer it's only, and the ulcer will have clear edge. In case of chronic anal fissure, the ulcer characterized by scarring of the edge, and there is what we call triad of chronic anal fissure: sentinel skin tag, hypertrophied anal papilla, thickening of the internal anal sphincter. And this picture showing patient with acute anal fissure, there's only the ulcer. And if we notice, the edge of the ulcer is clear. Here there is a chronic anal fissure, there is a scarring, fibrosis of the ulcer, there is skin tag, there is thickening of the internal anal sphincter, and here there is a hypertrophied anal papilla. This schematic illustration demonstrates this is the ulcer, this is a hypertrophied anal papilla, and this is a skin tag. This is a typical fissure, broad base and lateral location away from the middle line. What are the factors affecting the treatment for patients with anal fissure? The classification, typical versus atypical, acute or chronic, and the condition of the anal sphincter, if there is a hypertonia or hypotonia of the anal sphincter. We have different options starting from dietary modification and supportive care, topical agent, Botox injection, and surgery. And there is a trend toward minimizing the risk of permanent incontinence. So usually we prefer to start with dietary modification, topical agent, Botox injection, and preserving the option of surgery for patients who have fissure refractory for medical treatment. Dietary modification consists of high fiber diet accompanied by adequate fluid intake. It is important while increasing the fiber and diet to increase fluid intake to avoid bloating. And the target of fiber intake, 38 grams for men and 25 grams for women. And fluid intake, 2 liters of plain water per day. The outcome, desired outcome is soft, well-formed stool, can be expelled with minimal effort. Supportive care, including laxative, in case if the patient have constipation, this will be for 6 weeks. Topical anesthetic medication like lidocaine. Lidocaine will not allow the healing of the fissure or not contribute to the healing of the fissure, just for decreasing the pain. Warm seeds bath. This asking the patient to sitting in warm water for 10 minutes, and this allow relaxation of the internal anal sphincter. And the relaxation of anal sphincter allow to increase the blood supply to the fissure and allow rapid healing of the fissure. Topical agent like nitric oxide donor, which is nitroglycerin, and nitric oxide is a neurotransmitter, mediating relaxation of the internal anal sphincter. And as we said before, relaxation of the internal anal sphincter is important to increase the blood supply to the fissure and allowing the healing. Nitroglycerin applied in form of GTN, which is glyceryl trinitrate ointment, topically with concentration of 0.2%. The most common side effect is headache, and 27 up to 50% of patients complaining of the side effect. And the side effect led to discontinuation of therapy in 10 up to 20% of patients. For how long we should apply nitric oxide donor or nitroglycerin? For 6 up to 8 weeks, 3 or 4 times per day, and this to achieve complete healing. And this is important. Usually after prescribing GTN, the pain subsides after 1 week. But even if the symptoms disappear, we must ask the patient to continue in medical treatment up to 8 weeks, allow complete healing of the fissure. GTN is effective in 70% of patients. There is an alternative to GTN, which is calcium channel blockers like diltiazem, which is associated with lower incidence of fatigue. Botox injection. Botox injection is a botulinum toxin type A, and this is a neuroparalytic protein synthesized by Clostridium botulinum, and this protein inhibits the release of acetylcholine at the neuromuscular junction, and through this mechanism, it causes a local paralysis of the anal sphincter muscle, starting from few days and lasting up to 2 or 4 months. And during this period of time, this allows the healing of the fissure. And Botox injection, however, it is inferior to lateral internal sphincterotomy in healing and recurrence rate, but it has a value that it allows fissure healing while avoiding permanent fecal incontinence. Surgery, we have different options of surgery. Anal dilatation, now it is obsolete. There is no way to perform anal dilatation for patient as it is associated with a higher rate of incontinence. Fissurectomy, this includes excision of the anal papilla, skin tag, maybe the fissure itself. However, it is associated with poor result. This diagram illustrates how we perform fissurectomy. We perform complete excision of the fissure, and if there is an associated anal papilla, if there is skin tag, completely we will all removed. Internal anal sphincterotomy. It is the gold standard treatment for chronic anal fissure, refractory for treatment. There is different technique, posterior versus lateral, closed versus open. Actually, there is no difference in result between closed and open procedure. And if we are going to compare posterior and lateral internal anal sphincterotomy, there is a complication related to the posterior sphincterotomy called keyhole deformity, which is leading to fecal soiling up to 40% of patients. So now we usually perform lateral internal sphincterotomy, maybe closed or maybe open, but usually we prefer to perform open lateral internal sphincterotomy. We just divide the internal anal sphincter. There is no interruption of the external anal sphincter, as this will cause fecal incontinence to the patient. We just only divide part of the internal anal sphincter below to the dentate line. Sphincterotomy, as we said, it is the gold standard of treatment, is associated with a failure rate less than 10%. However, there is still a chance to develop fecal incontinence, maybe reaching up to 30 or 40%. And this is how we perform closed lateral internal sphincterotomy. Again, this is the internal anal sphincter, this is the external anal sphincter, this is the dentate line, and this is the fissure, this is the ulcer, and this is the hypertrophied anal papilla. We will introduce a knife without making an opening in the skin, and we just will divide a part of the internal sphincter located below the dentate line. And this how we perform open lateral internal sphincterotomy. This is a retractor, anal retractor introduced through the anus, and this is the internal anal sphincter, this is the external sphincter, and this is the intersphincteric groove. We make an incision over the intersphincteric groove. We start to dissect the internal anal sphincter from the external anal sphincter. Then we will define and locate lower part of the internal anal sphincter below to the dentate line, and we will cut this part of the internal anal sphincter. A last option for treatment of surgical treatment of anal fissure is anal advancement flap. And anal advancement flap involve fashioning a local flap to cover the fissure, may be performed alone or combined with fissurectomy and or Botox injection. What is the benefit of performing anal advancement flap? It does not disrupt the internal anal sphincter, so it is associated with a low incidence of fecal incontinence when it is compared to the lateral internal sphincterotomy. And usually we prefer to perform in patients who are high risk to develop fecal incontinence, or those who have hypotonia. What's meant by hypotonia? Decrease in the power of the anal sphincter. The result of anal advancement flap, healing up to 90%, complication flap disruption up to 7%, recurrence rate 6%, and incontinence 5%. And this is how we perform advancement flap. This is the anal fissure, this is the dentate line, and we will start make the incision of the flap. This is like a V shaped, and we dissecting the flap. The flap may include skin and subcutaneous tissue. Then we will bring this part to cover the fissure completely. And this the comparison of acute and chronic anal fissure. Regarding the treatment for acute anal fissure, dietary modification and supportive care is enough for treatment of acute anal fissure, and in case of chronic anal fissure, medical treatment, Botox injection, and surgery is the last option. And this algorithm is a very important algorithm. It summarizes the treatment plan of anal fissure, and we should remember, usually for treatment, it's important to know, is it atypical or typical anal fissure? If it is atypical, we will perform examination under anesthesia, taking a biopsy and culture. If it typical anal fissure, this depends, is it acute or chronic? If it is acute, we will encourage the patient to increase fiber, increase the water, giving him laxative, topical lidocaine. If this was enough, it's okay. If the patient if there was a treatment failure, we will treat as a chronic anal fissure. Medical treatment for 8 weeks. If failure occur, other option, Botox injection, lateral internal sphincterotomy. And remember, if the patient has hypotonia of the anal sphincter, consider advancement flap. If the patient diagnosed with Crohn's disease require multidisciplinary meeting, including gastroenterologists specialized in management of IBD, and maybe if we're giving systemic treatment like biological treatment to this patient, mostly 50% will not need any surgery for their fissure. And now the time for conclusion. Acute anal fissure less than 6 weeks and likely to heal with dietary modification and supportive care. Chronic anal fissures more than 6 weeks, and it need other line of treatment, including GTN, maybe Botox injection, surgery. Injection of Botox, it is inferior to the internal anal sphincter, but it allows healing of the fissure, refractory for medical treatment, and avoiding the permanent fecal incontinence. Lateral internal sphincterotomy is the gold standard for treatment of anal fissure refractory for medical treatment. However, it is associated with an increased risk of fecal incontinence. Good luck. Thank you. If you have any question, feel free to send this question to me on my email, mustafashalaby@mans.edu.ed. Good luck.